Velkommen til alle sammen. You guys can say it back, I guess. But so it's a special pleasure today to have the chance to introduce Jonas Dahl to speak to us. I, as many of you have also experienced, have been amazed and frustrated sometimes by our healthcare system and baffled by how it can cost as much as it does, and have wondered how countries do it that manage to offer universal health care to their citizens and visitors. I had a daughter that was born in Denmark, actually not far from where Jonas lives now, and was amazed that they didn't ask me to pay anything at all for the delivery and following care, even though I was a stranger and a non-citizen in that country. And so when Jonas said he was willing to come and talk about his work as the director of the regional hospital, I thought it would be something of great interest to us as not only as Americans and as consumers of healthcare, but also as Christians and members of the church who are concerned about the ways we can care for our fellow people and work towards a more equitable and just society. And so Jonas is particularly well suited to speaking to this issue, as he has also spent 9 years in the Danish parliament working to make laws that serve the people well. His father is a professor of comparative literature, which I think is a vote in his favor. Got him off to a good start. And he did his degree at Aarhus University, and immediately upon finishing his degree was elected into politics. And so he was very young when he started, and managed to become quite a figure of responsibility really quickly, became the Minister of Taxation, which is not a job that anyone wants to have, but everyone needs to have someone do properly. And after about 9 years in Parliament, decided that in the interest of his own sanity and his family's stability and just general life quality, he was going to move on to something else, and was given the opportunity to take over this regional hospital. He'd worked a lot on healthcare issues in the parliament. And so he's been doing that for just about 3 years now, and is going to tell us a little bit about how that system works, and maybe give us some ideas for how ours could work better. So thanks very much. Welcome, Jonas.
Well, thank you, Julie. And first of all, I would like to say thank you for the warm welcome me and my family has received here from the BYU. It's been really a pleasure to come here and being here for the last couple of days. And also must say that I've been truly impressed by so many of you who actually speaks quite a good Danish. And it's been really amazing for me coming 11 hours of flight and coming to the middle of the US, and then coming from a small country and meeting a lot of people who actually speak Danish and speak Scandinavian languages, but also are interesting in the Scandinavian culture. So that's really been a pleasure and truly inspiration for me as well. So just say, let me start by saying that I'm very pleased to be here today. What I would like to speak to you about today is a little bit about how the Danish healthcare system is provided for the citizens of Denmark. But I think you can, if you are Norwegian or Swedish, you can also say that this Danish healthcare is fairly similar to the Norwegian and Swedish model, as some of you may know better than the Danish healthcare system. But I think what's very important to remember is that the Danish healthcare is an important part of the welfare state, and was actually started out in the 60s when the Scandinavian countries decided to figure out how you should actually model the welfare states of the future. So healthcare is part of it. You can also talk about education, but I'm going today to talk to you specifically about how we arranged our healthcare system in the last 50 years and how we are today. But my agenda here today, just 3 points. I would start out by saying a little bit about the organization of the Danish healthcare system, and then also come with a bit of facts and financing on how we actually finance the healthcare in Denmark. And then in the final part, I would also say that we also have challenges in the Danish healthcare system, which is quite obvious. I think some of the challenges are similar to the US, but some of them are also different than the one you are seeing in the US, and maybe specific in Utah. But I'll come to that in the end of this presentation. First of all, I would start out by pointing out that there's mainly 4 principles you can say about the Danish healthcare system. First of all, you have universal coverage, which means that everybody gets the same treatment, and you can actually get it from different kinds of levels on the healthcare scale, and I'll come back to that in a little later. And then you have free and equal access, as Julie mentioned in her presentation. It actually means that all citizens of Denmark get the same treatment. Also foreigners, as well as immigrants, tourists, and wherever people come from, they're actually granted free and equal access to the healthcare system in Denmark. That doesn't mean there isn't a loss to ask visitors to pay an amount, but it's usually after the treatment, and it usually also is the only thing we ask for people to pay afterwards is medical expenses, medicine after you're written out of the hospital. So as long as you're in the hospital, it's free for all citizens, but also tourists and immigrants or who else comes to Denmark. I think that's, for me, is an important part of what also has maybe been a success in the Danish healthcare, that we actually provide the same service for everybody. Then there's, I think that's an important part also in the US context, is that the whole healthcare system in Denmark is financed by general taxes. That means that 84% of the healthcare sector as a whole is financed by general taxes, and I'll come into that a little later on as well. Then we also have a high degree of decentralization, which means that it's not the central government that makes all the decisions. We also have the municipalities and the regions, which I'm also coming back to a little later on. They actually have the power to decide where we're going to have these treatments and what kind of specialties we'll have in different hospitals. Let me start out here by saying a little bit about the organization of the Danish healthcare system. First of all, you have on the left-hand side, that's the country of Denmark, if anybody didn't know that. But it also tells you a little bit about the size of Denmark. You can cross Denmark, it's 190 miles across, so it's a rather small country. If you take on the national level, the healthcare system is maintained by the Ministry of Health. And then you have in the middle the regional level, where you have 5 regions, all with elected councils of 41 in each council. So that's the democratic level on the regional level as well as the national. Then you have the local level, the municipalities, where you also have local democracy, where they actually where people every 4th year elect the mayor and the city council in the local level. So we have these 3 different statutes and 3 levels in the Danish healthcare system. You have the national level, where you have the legislation in the Danish Parliament. It's the Minister of Health that actually lay out the laws, but they also make the national health policies, national targets, overall economic framework, and so on. But when it comes to the regions, they actually run the hospitals, they run the psychiatric care. But they also, and these are very important in a Danish context, the general practitioners, and I'll come back to that as well, because these are mainly the first point of contact that people that need healthcare assistance, they will visit the general practitioner before they visit the hospital. Then you also have the adult dental care and other private practitioners that are supported by the regional level. And actually this is one of the flaws, at least in my opinion, in the Danish healthcare system, is when you look at the dental healthcare, that's only provided for citizens up to the age of 18 on the public, it's when the public only pay until you're 18 years old. After that, you actually have to pay for yourself. So this is a part of the Danish healthcare system where you actually are completely privatized, but it also means it's actually quite expensive to have dental healthcare in Denmark. So there's actually here lies some of the trouble, and the history goes back actually to the 60s when you laid out the ground rules for the welfare state. There you decided that dental healthcare should be kept in a different manner, and all citizens should pay for that themselves. So there's a distinction here where dental healthcare actually is quite similar maybe to the US healthcare system, while the rest of the healthcare sector actually is nationalized and kept in a very strict national level. Then if we look at the local level, you have the 98 municipalities. They have the preventive care, they have the health promotion, they have all the elderly care, And they also have the non-hospital rehabilitation after operations. They are carried out on the local level, but also treatment of alcohol and drug abuse, child nursing, that's all a part of the municipalities. So you see, there's actually 3 levels where you actually receive healthcare from, and but mainly on the right-hand side, the regional and local level, where you actually deliver the services. The national level pretty much take care of legislation and policy, the policy level. So, but we actually changed the landscape regarding the hospital sector in Denmark quite a bit the last 10 years. If we go back on the left-hand side to 2007, we actually had all the red dots are hospitals back in 2007. On the right-hand side, you have the hospital structure now, where you have the green dots. That's the hospitals that have the acute care 24 hours. My hospital is, this is Randers. So now we have only 21 acute care hospitals, which also means that we have centralized a lot of it to bigger hospitals. We built bigger hospitals. Pretty much all of the hospitals has been built out in the last 10 years. So that has been a change for the hospital structure we used to have in Denmark. But what most people are interested in is, what do we actually do when you get ill? Here you have on this citizen on the left-hand side, you have in the Danish system, you have the family doctor, the GP, who is actually the first point of contact for most patients. Out of office services, when the family doctor is closed, the family doctor is open from 8 in the morning to 4 in the afternoon. But after that, you can call 911. In Danish, it's called 112. But that's where you actually get the ambulances, you get the acute care and brought directly to the hospital. But as I will come back to, the family doctor is for most patients the first point of contact. And the family doctor then directs the patients. Most of the time they actually finish off the patients, but they can also direct the patients to other specialists and especially to hospitals where most of the treatment are done afterwards. So let me just say a few points about the general practitioner, because I think that's a strong point in the Danish healthcare, and it's been historically also a strong point, but it's also in the last couple of years has become one of the weaknesses. We have roughly 3,500 GPs, and every GP covers 1,600 patients, each GP. And they have in contact, roughly 85% of the population is in contact with the doctor, the GP, every year. And in average, they have a Dane has 7 contacts with the GP. But that's also when you call in for prescription, for example, or renew your prescription, that's also a contact with the GP. And the GP is accessible 8 to 4, Monday to Friday, and afterwards that we have a different system that goes into function. Traditionally, we had the GPs working fairly on themselves, also in smaller villages, but in the last couple of years, most GPs, especially the young ones coming from university, wants to join other GPs to actually have a larger workforce, also employing nurses and physiotherapists. So we're seeing now that GPs are joining forces in most parts of the country. But we also have the trouble that we can't attract enough GPs into GP because it's difficult. Many doctors would like to stay in the bigger cities and don't want to move out in the urban areas. And that is a challenge that I think you've seen in all countries, but we see that same also here in Denmark. But let me then go on to say a little bit about the facts and the financing in the Danish healthcare. I think this is perhaps also where it becomes interesting in a US context. And I just heard this morning that you also, again, are discussing healthcare and how you're actually going to provide healthcare to the population in the coming years. But in Denmark, every individual pay 8% of their income tax directly to healthcare. So we have an 8% healthcare tax, you can say. It's collected by the government, by the Minister of Taxation, and every Dane pays roughly 47, 48% in taxes. That's another story. But 8% in the general taxes, that is directed to the healthcare sector. So the government claims these 8% in healthcare tax and direct a block grant to the regions, which roughly is 80% of the revenue in the regions. And then the municipalities have a co-financing for the last 20%. And the municipalities pay a co-financing depending on how often their citizens use the hospitals. So there you have actually a relation in how many visitors how many patients are going to the hospital. So it's dependent on the municipality, and the municipality has to pay the region for using the hospitals. But I think this is actually where it comes down to what do you actually pay as a Dane for the Danish healthcare system. So that is pretty much the 8% you pay in healthcare tax. And I think if you transfer that to the US context, you all have to consider that how much, I don't know how much you pay your national taxes, but you also have the insurance system, and which is very uncommon in Denmark. Few people have a healthcare insurance policy if you are working in a private company, but it's rarely used and it's fairly cheap because most services are delivered by the public sector anyway. So just to give you an understanding of also how quickly it has to be done in the public sector, we have a law in Denmark that says that after the GP, if you go back to this slide, after the GP sees the patient and says, okay, I'm a bit unsure, maybe you need to see an orthopedic surgeon on the hospital, then the hospital have 30 days to see the patient and start treatment of the patient. If it's acute, obviously then it's acute, and that's, if you go to the hospital in the acute department, you'll see a specialist within 1 hour. And that's the law, it's something we have to provide from a hospital level. But if you are a patient that is not urgent, then you can actually have your insurance that the hospital actually is going to give you an appointment within 30 days and start a treatment within 30 days as well. So there you have a very strict legislative rule that actually makes the healthcare system also quite effective, in my opinion, because we have very strict control if we actually deliver this 30 days guarantee to the patients. And each month, actually, I, as a director, draws data from all our doctors and all our departments and can say, okay, you are delivering 85 or 95% of all patients within 30 days. How can we actually get better at that? And there's we need to be, as a hospital as a whole, we need to be on top of 90% each month in delivering healthcare within the 30 days. And we actually deliver that at my hospital. So that is an important rule also as a patient to know that you actually have a guarantee to see a doctor within the 30 days, or a specialist. It's important not to see a doctor because you've seen the doctor, the GP, but the specialist you're going to see within 30 days. But let's get back to the financing part. If you see at the Danish healthcare where we're actually spending the money, there you can see on the left-hand side that the municipalities spend roughly 26% of the whole healthcare spending, and the regions take the other 73%. And if you look into the regional spending, there you can also see that most of the money, the blue dot, the blue line, is put into the hospitals, and the red part, the 8%, is for the GPs. So actually, the GPs also, they make quite a good money in Danish style. The GPs are one of the best earning doctors in the Danish healthcare system, because all the specialists that works at the hospital are actually, their wages are provided by the hospital, but it's an agreement with the labor union, so they have a fixed salary, all the doctors. There's usually some, some discussion you can actually maneuver a little bit around, but it's very little in the general terms. So most of the hospital doctors' wages are according to labor unions. So if you also look at a little bit about the how we actually spend this money, there you have the 8% of the general practitioners get 8% of the money in the healthcare system, but they actually finish off 86% of the, they are in contact with 86% of the, population during 1 year. If you go on to the hospital side, which are the expensive part of the healthcare system, actually 47% of the population receive outpatient treatment in a hospital, and that's not including the psychiatric hospitals. And then you have 12% of the population that receives inpatient treatment in a hospital during 1 year. But I think, for me at least, that has been also an important part of getting the financial, keeping the financial difficulties down. Because when you look at the Danish hospitals, these are on the right-hand side on this curve, we have a very high number of nurses, as you can see here, but also a high number of physicians per bed. But if you look at how lengthy stay the patient actually have in the hospital, that's fairly low. So actually, in my opinion, it's a very important part of actually keeping an efficient healthcare sector is to have a high number of nurses and physicians per bed, but also that helps actually keeping the average stay for the patient fairly low, also internationally comparable. Actually, my hospital is actually down to 2.2 days stay when we treat patients. Obviously, we don't treat all patients, so some of the cancer patients are treated other places, and they have lengthier stays. But it is something we are looking very much into, because it's important also to get the patient back into their own home. Not just because we want them out of the hospital, but also mainly because you can start rehabilitation quicker in your private home. But it's also the risk for infections even though you try to keep it down in the hospitals, the risk for infection is much higher at a hospital than there is in your own home. So we actually, for the patient's safety, want them to go home as quick as possible. And then how do we compare all this? You have the GPs, you have a 30 days guarantee how quickly you can actually get access. But I think what's also important in international, comparability, is that is it more expensive than other countries? But if you look at Denmark, it's pretty much the same price we pay per GDP. Roughly 10% of the GDP is spent on healthcare in Denmark. It's very similar to Norway and Sweden, as you can see here. But then on the right-hand side, you also have the US. So I would, in my opinion, say that we also have a very efficient system where I would say to you as an American, there's probably a little room for improvement if you look at how much money you actually spend on healthcare. And in that regard, it's also important to remember that in Denmark, Norway, and Sweden, all citizens are included in the healthcare sector. It's not like we exclude anybody. Everybody has full access to all hospital treatments during, if you need a lengthy stay, for example. Then, if I need to look a little bit here on the in the end, a little bit of the challenges in the coming years, because it's also important for me to say that it's not just a happy story about the Danish healthcare system. Even though I would say that many things is working quite well and has been working quite well for a number of years, there's also challenges we can see in the nearby future. Obviously, we are also seeing the challenges regarding employing doctors. In the hospitals, we've actually seen an increase in employed doctors during the last 12 years. 50% more doctors has been employed at the hospitals. So we actually are educating more and more doctors every year. But a doctor is also an expensive part, even though they don't get as high wage in Denmark as they would do in, for example, the US. The average wage for a doctor in Denmark is $150,000 each year, and that's pretty much the average. And fairly few earn a lot more than that. Some do, but very few. So it's still more. It's a challenge to a budget to employ more doctors instead of nurses, because a nurse would earn roughly 1/3 about a doctor's wage. But if you look into the challenges from my point of view, we are seeing a few mega trends in the Danish healthcare system, and I think part of that is also something you can see on an international level. We are seeing new and more treatment. Obviously, Medicare industry is finding new treatments, which is good for a patient perspective, but it's a challenge if you look at from economical side. We need to find room to actually treat a patient with the newest and best treatment possible. We are also seeing an increase in lifetime, so people get older. That is a challenge also in the Danish system. And we have on the blue curve, you can see the aging population. That is a challenge the next 10 to 15 years. Then it pretty much, it's became acceptable again. But during the next 10 to 15 years, we're going to see a huge challenge in the Danish society because we have a very low birth rate. So that is going to be a challenge when we look forward. So pointing out the aging population, aging workforce is a challenge, rise in chronic diseases and comorbidity. Then we also have some possibilities. We can actually look more into big data. In Denmark, we have a CPR number, which pretty much is like a social security number as you have in the US. But it also means that we actually have had that for many, many years. So it actually means if I log into my CPR number, I can actually see that I, as a 2-year-old, had eaten mushrooms in my parents' backyard, so I was admitted to hospital when I was 2. So they have this whole story about my healthcare, which also is important when I come into a patient. They can actually see that you were here last year and you were treated for this and this. Even though if I go to a different hospital or a different region in Denmark, they can actually look into my medical history. But we have possibilities also in this big data. Actually, medical companies are coming to Denmark right now because we have this strong history. So we can actually look upon patients and say, this patient was treated for this and this 25 years ago. And that is very important also if you look at how you can use big data, but also give us a chance to actually maybe find better treatments for patients because we know not their own history, but maybe also their parents' medical history. So, but we're also seeing health consumer market data, interest in that, which is quite obvious for big companies. And then we're also seeing disruptive technologies, genomics, artificial intelligence. It's also very interesting because when we can actually learn from the history that other patients have had, that it actually is a possibility in the future. Then we have new demands. Also, Google is I think for many doctors is worrisome because a patient would come in and say, okay, I know I have all these diseases and you just give me the treatment. And the doctor also have to put his professionalism into it and say, maybe you don't have cancer, maybe you just have a flu. But that is a challenge sometimes, that actually the patients have a feeling that they even know better than the doctor what they're actually, what their diagnosis is, even before they arrived at the hospital. If you also look at challenges in a Danish context, we actually have a huge challenge regarding smoking and tobacco. I saw new data the other day that I think 23% of young Danes actually have started smoking, which is a rise for the last 5 years. So that is a huge challenge that youngsters now are beginning to smoke more than they used to. And even though we're telling people that how dangerous smoking is, there seems to be a bit of a, I don't know, a filter or what do you call it, stealth on the youngsters, because they seem to not accept that smoking actually is as dangerous as it is. And I just heard the other day a young person saying that, okay, I can just quit tomorrow and then in a couple of years my health is going to be fine again. But the problem with smoking, as you all know, is that it's addictive as anything. So that is a challenge. And in Denmark, we're discussing if we should hire the price for a box of cigarettes. But the problem is that the politicians are very afraid to do that because they're afraid of the border traveling across borders and buying cigarettes in Germany, because we have the connection on the borderline with Germany. Then you also have a lot of mental stress in Denmark as well, as I think you're seeing in all Western countries. And then I think what is worrisome as well is that we have a very high alcohol consumption in Denmark. And in my hospital, we have roughly 220 beds. And I would say every day, every year, we have roughly 10 patients where alcohol is the only reason why they're at the hospital. So that is a huge, I think, concern for me as a director, but it's also a concern for the society as a whole that we haven't been very good at limiting alcohol in Denmark. And maybe it has to do with we have Carlsberg as a brewery in Denmark, but there's a lack of willingness to actually have a restriction on alcohol in the Danish population. And that is a major obstacle when you look at the healthcare system and how you can actually provide better healthcare in the future. Then we also have 29% who are physically inactive. And then if you look at the overweight, I think it's very similar numbers to the US. But 51% are overweight. That is a challenge looking into the future, and it's going higher and higher. And we need to figure out both. I think smoking, alcohol, and physical inactiveness is going to give us better results in the overweight department coming into the future years. But let me also say a little bit about what the transformation we've done in the healthcare sector. If you do look at this, we've done from organizational units. In 1980, we had 128. Now we have 20 or 21, a little bit depending on how you look at it. But we are also seeing more discharges from the hospitals, but we're seeing it tripled regarding outpatient treatment, which is good because it's effective. But the number of beds in the Danish hospital has lowered quite a bit in the last 40 years, and the admission days as well. So we're actually seeing a transformation of the Danish healthcare system also right now when we are looking at it. And I think it's going to be more effective, but also cheaper for the public in the future, because you can actually turn patients around and keep them as outpatients instead of admitting them to hospital beds. If we look a little bit ahead also, then we have an outpatient strategy which actually tries to look into how we can keep the diagnostics and treatments in the patient's home. We make the GP responsible for treatment of the big chronic diseases, which is important because as you remember, that the GP actually sees the patient on average 7 times. So if they also are responsible for the treatment of the chronic diseases, that is going to give better results for the patient as well, instead of the hospitals. Then we are strengthening the patient's empowerment. We're looking into same-day surgery, if possible, cut down over-treatment. One example for same-day surgery is that we are now, if you have a hip fracture, or column femoris, as you would call it, usually it used to be that you would be in bed for 7 to 10 days a couple of years ago. Now we're actually doing same-day surgery, and on day 2 we usually send the patient back home, which gives better results, and actually start the rehabilitation in the citizen's home earlier, and the municipalities take over the rehabilitation. So it's actually going in the right direction. Then we're also looking into how the hospital can change, become more outgoing and outreach for regarding to the patient. One of the things I'm very interested in right now is actually how we can also look at what we call in Danish PRO, patient-reported outcome, where we can actually look at from the patient's perspective. And I think this is also important in the US context, because sometimes we tend also in the Danish system to overtreat the patient, even though the patient has actually said, I don't want this treatment. I actually want to just have some pain relief, because I accept that at some point I'm going to die from my cancer. I don't want to be, as we sometimes say in Danish, treat myself to death. So I think what we are looking very much into now is how we can actually listen more to the patient, and actually keeping the doctor responsible to have the communication with the patient, so we actually understand from the patient perspective what would be the best for this patient. And that might not be best for the other patient, but because all patients aren't similar, even though they have the same disease, it doesn't mean they should have the same treatment if they actually want something else. And then if I look a little bit from my point of view into the future, I think we're going to see more of what we're calling learning and quality teams for each areas of disease, because we want to learn. Sometimes one hospital has found what's working very well, but we need to be better at learning at each other instead of looking into silos. We need to continue the use of indicators, a joint quality organization. We are starting to build that up in Denmark. And we are including the entire patient journey. We're not just looking at the patient journey at the hospital, but we are seeing the patient journey from the first point of contact with the GP to the actually rehabilitation in the citizen's own home, and which is done by the municipalities. Then we also looking into how we can continuously challenge and improve patient quality and quality as a whole, and how we can also get professionals engaged in quality improvement daily. And that has something to do with how can I actually keep the contact by video, for example, contact with the patient on a daily basis. That is giving good results in a number of disease areas, so we're looking into how we can expand that. And then finally, we have currently 5 focus areas in the Danish system. The patient as an active partner, knowledge on time and prevention has a lot to do with alcohol and tobacco, as I talked a little bit about earlier on. And then trustworthy and secure data. We need to be very sure. We collect a lot of data in the Danish healthcare system, but it's very important that the patient actually feel trust in us keeping the data secure. And then in the last, we're progress in common building blocks. We're actually trying to see how we can build for the future. And then in what is in my personal vision is also that we can have a digital and structural transformation of healthcare. We've done the structural, now we're looking into the digital transformation of the healthcare system in Denmark. But it needs to be coherent and sustainable healthcare system where we deliver healthcare for all at the lowest effective cost level. And it's important for me to point out that it's important, I think, for all Danes, and it's been important for our politicians to say that we need to deliver the same kind of healthcare regardless of your income, regardless of where you live in Denmark. But we also need to keep it efficient on an economical level, and that has been important for the last century, that we are also looking into how we can actually cutting costs all the time and actually keeping a short waiting list on patient treatment, but also keeping the guarantees that the politicians has given out, especially regarding the 30 days guarantee to see a specialist. So that should be my presentation, and just a quick then remarks from my side, a little bit about how we're organized in the Danish healthcare system, how the financial situation is, but also a little bit about what we see in the future as troubles. So I would say in many ways we have a very efficient healthcare system, also where you can treat it for pretty much any disease. And if we can't treat it in Denmark, you are actually allowed to seek treatment outside of Denmark, but it's paid for by the hospitals if you need a treatment in other countries. So it's also important to say that there isn't any treatment you are not allowed to get in the Danish society. So that will be my final remark, and I'll be happy to take some questions.
Heard as well as the response to the question, and just your student, tell us your name, what you're studying, and please.
Eric Christensen from the Geology Department, not a student. My question is follow up on what you just said about limits. There must be some things you don't cover, cosmetic surgery, things like that. Where are the limits in regard to those more elective kind of things?
Regarding the cosmetics treatment, it's usually dependent on if the surgeon says that, for example, it would be a good thing for you to have a breast reduction, for example, then it's done on the public. It's public paid. But if it's something that you need fully cosmetic, then it's on your own. So you have to pay it by yourself. Yes. So there's limitations, obviously. Yes. So it's always, it has to be a medical judgment whether you can get it from the public sector hospitals.
Hello, Jonas. Thank you for coming to BYU. My name is Nick Ergitz. I'm a chemical engineering major. 2 questions. First, you mentioned that acute care recipients are by law supposed to receive care within 1 hour and all other care within 30 days. That's the law. How do hospitals manage to achieve that?
We have doctors that pretty much greet the patient when you come in the acute department. So we have acute doctors on call or on site all day long. So if you're coming to the acute department, usually a specialist or acute doctor would see you and say, where you're heading? Is it something that he can finish off, or do you need to go to a specific ward at the hospital? So in that regard, that's working quite well. Regarding the specialist, you need to see within 30 days. You've seen the GP, and he says you've blown your knee out, for example, but it's not acute, and then you're going to receive a note from the hospitals. So we are required to give you a time within 30 days, and 92%, I think, of the cases, it's possible for us to do. If we can't, then we also have to let you know that we can't see you within the 30 days, and then you're allowed to seek treatment for the hospitals. The hospital has to pay for, and you can go to the private sector, and it's fully paid for by the hospital, by the public sector hospital.
Okay, great, thanks. And a second question, if
Yes.
I may.
Yes, sure.
When you compared the GDPs,
Yes.
expenditures between the Scandinavian and other Western European countries with the US, one economist I follow named Thomas Sowell, though there be many inefficiencies in the American system, I don't think anyone would disagree with that. One thing that he posits is that at least part of the difference is that the quality of care, or at least the amount of care that Americans voluntarily choose to pursue, is a bit higher in the United States. Do you have any data that would compare the quantity and quality of care that is consumed in the United States compared to the Scandinavian countries?
I think the quality, I would say, is very similar, but I think the amount of treatment you would receive in the US is higher. So you will probably get the same treatment, but you would stay hospitalized, stay in bed in more days in the US system, where we are very focused in the Danish and the Scandinavian countries, focusing on bringing the patient back home earlier on, and I think that's also an economical issue, because it's more expensive to have nurses and doctors around the patient if they can actually manage by themselves, and maybe with a visit from the doctor or nurses from the municipalities, and that would be the nurses then, if it's from the municipalities, they would visit maybe the patient 2 times a day, but that's more efficient and it's cheaper to keep the patient in their own home. So if my understanding of the US system is you have lengthier stays at the hospitals. Yes.
Thank you very much.
Hello, my name's Ryan Sabin. I'm a nutritional science major, and I was just wondering, like, what effects you've seen the Danish healthcare system has had on, like, the levels of research that are done. I know that's, I think, one of the strong parts of the American system is we pay for over half of the research in the world. But just what your thoughts were on how that affected, what effect the Danish healthcare system has had on the research that's done there.
We have I think I would say 20-25% of our doctors have a PhD degree. So we have a number of doctors at my hospital. We have roughly 200-250 doctors. So 25% of them have PhD degrees and has done some research in their medical, in their, let's say, professional career. So we actually have a strong tradition to have research in the Danish hospital sector, but it's also, I think, in fairness, it is fair to say that especially Novo Nordisk, the big diabetes company from Denmark, is supporting a lot of research in Denmark. So you have also a private company that is spending a lot of money, but it is also spending a lot of public money, but that's mainly done actually from the universities and not as much in the hospital side. Then it's usually the university that brings some money, and then the hospitals give the doctors time to research during their stay at the hospital. So it's a combination of private sector money, but also a lot of public sector money goes into research in Denmark, and then the hospitals usually deliver the doctor's hours.
Good afternoon. My name is Earl Brown. I'm in the Department of Linguistics. Here in the U.S., children in primary schools are taught about good nutrition, and they're presented with a food pyramid that emphasizes plant-based foods more than animal-based foods, like grains, fruits and vegetables more than meats and dairy. I was just curious to know in Denmark if that's the case, if what the status is of teaching the public about good nutrition.
I think it's very similar. My daughters who are sitting out here, they, especially the oldest, would know the pyramid of nutrition. So I think we've actually, I lived in the US 25 years ago, and I think it's very similar the way we look into nutrition, but I also think we are looking into the same worry that my daughters would ask me tonight if we could go to McDonald's, and also the trouble about eating a lot of fast food. So I also showed a slide that we are having trouble with overweight in Denmark as well, and that's especially coming from our youngsters that exercise too little and eat too unhealthy. But I think a little interesting part is also, I can't remember, it was a nurse that asked me yesterday regarding the vaccines program for kids in Denmark, and asked me how many Danes do actually get the vaccine. And I think that was an interesting question, because all Danes usually get the umbrella vaccine, it's called in Danish. It's 3 shots during I think it's starting when you are 3 months, and then when you're 3 years and 5 years, I think it's the Danish protocol for that. But that's free of charge as well, so it's done as part of the healthcare system. And I saw the other day that the US, I think it was in New York, you had the measles outbreak, and I think that's part of the efficiency also in the Danish system, is that because the GP sees the patients, he actually also pretty much ensures that all the children are given the vaccine that they need. So that's also part of the regarding the children. Yeah.
My name's Chip Oscarson from Scandinavian Studies. My question has to do with kind of the historical roots of the healthcare system. I mean, I think one of the big differences between the United States and Denmark, and the Scandinavian countries generally, is that there's more a sense of mistrust between individual citizens and the government in the United States than there is in Scandinavia. And so, I mean, you talk about 47% taxation. Danes see that they get benefits from that, and they trust the government to treat that, to take care of that. How did this come about in Denmark? Where has the healthcare system developed from? I mean, what are the historical preconditions that made it possible for it to develop? I mean, this is too big of a question. But I mean, what are some of the key things that made it possible as we think about what can be adopted here in a place like the United States?
I think it has to do a lot about luck. To be frank, I think our luck was in the 60s and the 70s. First of all, we found oil in the North Sea. So we actually had quite an income from North Sea oil in Denmark and Norway as well. And there was a willingness to actually put part of that money that was earned in the state to actually build new hospitals, build schools, and build a welfare state in the 60s and 70s. And there was also a strong urgency that we actually needed to do something as a whole in the country. So I think the country came together in the 60s and 70s, and part of the money that was retrieved from the North Sea and the oil actually was spent into the whole welfare state and building universities, high schools, hospitals. So that has been, I don't think, luck pretty much, that there was historical support for building the welfare state in the 60s and 70s, and that has kept on for many years now. But we're also seeing challenges now in Denmark that some people are saying that should be the taxation is too high, we need to lower the taxes and people must pay more by themselves. So that has been a direction that has turned for the last 5-10 years, where we are having more of a tax discussion in Denmark than we used to have in the 80s and 90s. It wasn't a big discussion then, but it has been for the last 10-15 years. So we are seeing a change in that direction as well. But historically, I think it has to do with the easy money we actually received in the North Sea. That's a simplified conclusion on a very broad, discussion. But I think it has some truth in it, especially in Danish and Norwegian perspective.
Thanks so much for your presentation. It was fascinating and informative. I'm Riley Norton. I'm a computer science student. My question was kind of alluded to earlier. I don't remember your name, but I think in the United States, as we consider like this disparity in the cost of the healthcare system and the possible alternatives, I think there's this common perception that under the current system, if you can pay, and that's a big if, that you will receive the best possible care. And earlier, so you mentioned about, in response to the question about the quantity and quality of care that citizens receive in Denmark, you mentioned the number of days, the average length of stay in the hospitals. Do you have additional metrics or more information, especially that might be useful to us, to compare for quality of care and patient outcomes in Denmark? Is there anything else that you look at as kind of key indicators or useful metrics?
We have a bunch of key indicators where we're looking into how we actually doing compared to other countries. And I think if you look at the quality, it's fairly similar. I would agree that I think if you have a good insurance in the US, you would receive excellent care in the US as well. And that would be very similar to the treatment you would receive in Germany if you have an insurance, or France, for example, or Denmark and Norway and Sweden, where you have the welfare system. But so I think the treatment as a whole and the quality, that's fairly similar. Obviously, you can find a distinction in that, but I think if you look at the broad perspective, I think the quality is fairly equal, and there's a willingness also to learn in the Western world, learn from other countries. And Denmark started out by giving diabetes medicine to the whole public that needed it for diabetes, and that has been rolled out to other countries as well. So I think, and that we didn't do that from altruistic reasons, we did it because we have a huge national company that actually wanted to have a market and wanted to show that they could sell diabetes products for all the diabetics in Denmark. So that's a business story also. But so I think if you look quality-wise, it's fairly similar, but I think the challenge is in the US system that is the one who doesn't have an insurance policy. But also maybe looking into is it comparable on efficiency? And I think what we are looking very much into in the Danish system is we want the system also to be very efficient. We are trying to find the slack all the time and seeing how we can cut days in bed and actually send the patient back home. It shouldn't be a risk, but it should be still a quality-wise. If it's the right thing to do, we should do it quality-wise. We shouldn't do it on economical reasons.
My name is Kimberly Hansen. I am an epidemiology student, and I just wanted to return back to the question about vaccinations. Just on a public health standpoint, a big problem here in the U.S. is that there's a claim that many parents are avoiding vaccinations for their children with the claim that it causes autism and other health problems. And I'm just wondering if there's a similar problem, a question in Denmark, and if so, how the government and healthcare and how the healthcare system are combating that.
I think it's called HPV virus in the US as well. Actually, we had, when we included the HPV virus in the free vaccine that was only for girls in the beginning. It's now expanded to both boys and girls. But when we started giving that vaccine, I think it was in the beginning of the 2000th century, we had the difficulty because we had the exact same discussion as you had in the US, but we had parents coming out and saying that their daughters were getting ill because of the vaccine. So we have done a lot of research, and I think in the last 2 or 3 years it's changed back, because we saw a huge drop in a couple of years where, especially in the HPV vaccine, parents didn't want to give them there. So I think the it was rolled out to roughly 50%, 55% in the low years, and now we're back to 85%, I think, in the HPV virus. So we've changed that, but I think what we did, and it took 5 to 7 years where we had a public discussion about the, bivirkning? Side effects from the vaccine. So it took 5 to 7 years to come over the side effect discussion. And I think what we did was we put the doctors in front of it. We put the doctors out saying that these side effects are not scientifically based. It's not relevant in regard to this vaccine. And I think the doctors in all countries as a whole has a very strong public opinion. When they go out, people tend to accept it. So, but I think the medical society in Denmark became very concerned that we saw this huge drop in the correspondence to getting the vaccine, and the whole medical society actually engaged in that discussion. And I think that was a very strong commitment when they did, and also changed the public opinion about the vaccine. So now we're up to 85%, I think, on the HPV vaccine, and I think on the children's vaccine we are, I think, 92-93% currently, which is acceptable for at least usually.
My name is Tanner Cox. I'm an international relations student. So I have 2 questions. One question deals with this immigration. Has immigration been a big problem for Denmark? And if so, has that had an impact upon the Danish healthcare system? Because you'd have a huge portion of the population that's coming in that might not be able to pay that 8%, depending on their circumstances.
We've had huge discussion regarding immigration in Denmark as well as Europe as a whole, and I think if you go 3 to 4 years back, we all saw the immigration crisis coming from the Syrian refugees that were rolling in across the European borders, and we saw that it was a huge discussion, and still is a discussion in Denmark. But there's a tendency to say that even though you're an immigrant in Denmark, we're not. You get the same treatment. So we have a refugee camp not far from my hospital, and if they come in, we'll treat the patient as everybody else. And I think most doctors in Denmark would also say that they have they sign when they finish off their med school. They have to sign off. They're going to treat all patients, and it's very important for them to also have the possibility to actually treat all patients equally. So they do that regardless of if they're an immigrant or if it's a citizen. So it hasn't really changed there. I think where it has perhaps changed a little bit is if you need to receive medicine afterwards, then you're going to have to pay for it yourself. But the 8%, we're not going. It's collected during the general taxes. So if you earn, I don't know, 100,000 Danish kroner, then it's 8%, but it's also 8% if you earn 1 million, then it's just more. So we don't look into these 8%. It's something that's done over the taxes, so it's not an issue when you come to when you arrive to the hospital.
So I guess my second question is, you mentioned that how the Danish healthcare systems impacted Scandinavian healthcare systems. Do you think are there big differences between Norway, Sweden, Finland, and Denmark in the terms of their healthcare system? Again, that's a kind of a big question, but what are some of the main differences?
I think there are many similarities, I would say, and I think that we influenced each other. if it's also, there's a tendency to, a lot of Norwegian doctors used to be educated in Denmark and travel back to Norway. So we've had a lot of exchange from doctors working in Norway and Sweden and Denmark. So it's influencing each other at all three countries. And I think Norwegian, Swedish and Danish healthcare system is fairly similar. The Finnish system is a little bit different, but the three Scandinavian or classic Scandinavian countries, that's fairly similar system. And maybe there are also some that is not completely similar, but in the broad picture, it's very, very similar.
Tack så mycket.
Velbekomme.